Good evening, everyone. Thank you for your participation today. So today there are two topics. First topic is chronic kidney disease principles of management taken by Dr. Jitendra Meena, and second topic is avoiding dysfunction by Dr. Sumantra Rao. So over to Dr. Sumantra for the first session.
Hello everyone. So without wasting much time, we are going to start our sessions because today we have back-to-back sessions like any other day. Though we are in the middle of our total teaching program, so we like you to be more interactive, and if you have any doubts during this whole program, you can post your answers in the chat box. Our speakers will answer it directly after the end of sessions, or in between we will try to answer it if it is possible. So what to Dr. Jitendra? Dr. Jitendra is currently attached to PGI Chandigarh as a pediatric nephrologist. He is one of the best alumni from AIMS New Delhi, completed his DM fellowship. So over to Dr. Jitendra. His topic is today regarding CKD in pediatrics. Thank you.
Good evening, everyone. Am I audible, Georgie?
Yeah, audible slide.
Yes.
Go ahead.
Yeah. So today will be over next 40 minutes or so. We'll discuss the chronic kidney disease. As such, CKD is a vast topic. So I will try to touch, the various aspects and chiefly the principles of basic management. I won't go into too much of detail, because at your level, I don't think that is required to discuss each and individual complication and their management. So, so learning objective for today's class, that at the end of this class, you should be able to define and stage CKD as per GFR and proteinuria categories. And you should be able to enumerate the common etiologies of CKD in pediatric populations and how to approach a patient if it's come to you in OPD with the chronic kidney disease. Then, the various complications and their basic management. Then we will also have a look at the various options of long-term kidney replacement therapy. So coming to definitions, chronic kidney disease is defined by the abnormality of either kidney structure or function, which should be persisting for more than 3 months, and it should have the implications for health of that particular patient. The first definition of CKD was staging was provided by Kedoki in 2008. So they have staged these various stages of CKD as per the glomerular filtration rate category. So in pediatric population, we use as of now the modified SWOT formula for estimation of glomerular filtration rate. So as per that, we have various stages of CKD from stage 1 to stage 5. These stage was further refined, and there was improvement by the KDIGO in 2012. So apart from EGFR category, KDIGO has added the albuminuria category as well. So now we have GFR category from G1, G2, G3, G3B to G4 and G5. Then albuminuria category from A1 to A3. So this figure is basically called heat map. So if you look at this green color category, which is G1 and G2, and with albuminuria category of A1. So this basically, this color are depicting the rate of progression to ESRD. So if you are categorized in green, you are at very low risk or a very low rate of progression to ESRD compared to categories which are depicting in that color. The maximum risk of progression or rapid progression to ESRD is in G5 and A3 category. So coming to the I would start with this case. So this 6-year-old boy presented in OPD with history of fever since 5 days with dyspnea and failure to thrive for over last 2 years with history of dribbling of urine for almost 2 years of age with these vital parameter, and he was found to have stunting, wasting with the pallor, and there was pedal edema as well, but there was no evidence of bony deformity. On respiratory system examination, there was bilateral cramps. So what's the likely diagnosis, and do you want any further information to make diagnosis in this kid? You can reply in chat box. Hello?
Yeah, audience can put their suggestions or answers in the chat box.
Is it possible to unmute them and they can speak to
Okay, just give me a second.
maybe whoever want to speak or
Yeah.
reply.
Now all audience can unmute themselves and speak.
One answer is regarding renal function, urea and creatinine. Some ask for facial swelling.
So first you would
Someone
want
asked for ultrasound.
making the clinical diagnosis rather than going for investigation. So first question is if you want any other specific information based on history and physical examination. But we'll come to investigation in question 2.
Yeah, one participant answered regarding facial swelling. Is there any facial swelling? Yes or no?
No, so no history of facial swelling in
And they
past.
asked for palpable kidneys.
No palpable kidneys.
Okay, good going. Good response from the audience. Very good. Anything more?
Anybody want to comment on the likely syndromic diagnosis and underlying cause? So urine output has been decreased since last 3 days.
Okay, so we can gradually proceed, and after few slides, we can have more such answers from the audience. The audience keep posting your answers on the chat box.
Yeah. So I think we'll proceed, then we'll come back to this case maybe after 3-4 slides.
Yeah, it's fine.
So coming to the etiology of chronic kidney disease in pediatric population, they are definitely much contrast difference in the adults, where mainly are the hypertension and diabetes mellitus leading to chronic kidney disease. In pediatric population, you can divide underlying etiologies into basic groups, which is non-glomerular and glomerular. Under the non-glomerular causes are chiefly the structural malformation affecting the lower urinary tracts are there. So it's maybe primary vesicular tract plaque leading to tract nephropathy or hypodysplasia or obstructive uropathies. So all these three causes almost form the 50% of your CKD in pediatric population. Then you might have the ciliopathy inherited causes like ARPKD, ADPKD, or nephronophthisis spectrum. Then there are other rare diseases like cystinosis, primary hyperexuria, or dense disease. So glomerular forms almost 30%. So these the percentage can vary across various centers depending on your reference bias or across the globe, but almost 2/3 and 1/3 kind of subdivision. So under the glomerular etiology, you can have focal segmental glomerulosclerosis secondary to steroid-resistant nephrotic syndrome. Then you can hemolytic uremic syndrome, then familial nephritis like Alport. Then you may have chronic glomerular nephritis leading to CKD, which can be secondary to various underlying cause of primary glomerular nephritis like IgA nephropathy and associated vasculitis or lupus nephritis. So if you look at the overall data from India, so this is a cohort of kidney patients who underwent kidney transplantation. Their more common cause is almost in 20% patient is reflux nephropathy, which is associated with primary vesicular reflux, followed by FSCS. Then you have obstructive uropathy like posterior urethral wall, neurogenic bladder, and PUJ. So one point I want to highlight here is, that despite extensive workup, and because the patient has underwent kidney transplantation, they have been worked up extensively. Almost, 1/5, almost 20% of the patient, in the 20% patient, you can't identify, the underlying etiology. So that is, across the globe, not only in India, across the globe, almost like considerable proportion of patients have an unknown underlying cause of ESRD. So coming to the approach, a patient with chronic kidney disease. So your approach is chiefly depend on, if you remember the underlying etiology, it would be easy for you people to take history and focus on clinical examination as well as looking at the investigation. So while approaching a patient with chronic kidney disease, you need to look at both things. One is, to evaluate the underlying cause. Simultaneously, you need to look at the complications associated with chronic kidney disease. So failure to thrive, anorexia, fatigability, pallor, and bony deformity, these are kind of, the marker or suggestive of complication associated with chronic kidney disease. If you have past history or recurrent episode of hematuria, cockiness, oligoanuria, is likely suggestive of some form of chronic glomerulonephritis. If there is a history of polyuria, nocturia, polydipsia, night blindness, is might be suggestive of nephronophthisis. Recurrent UTI are again suggestive of reflux nephropathy. Then you have aortic dysfunction, dribbling of urine, pointing towards either neurogenic bladder or posterior atrial wall. One thing which is now increasingly becoming common with development of newer easily available genetic technology, that we are diagnosing more of familial
Jitendra, your voice is breaking.
While evaluating utilization, you need to look at your vitals, related chronic changes, and aspiratory answer. So then anthropometry is pretty crucial in CKD patient, because most of them would have some or other evidence of the growth failure. So you need to look at the stunting parameter for stunting, wasting, as well as other evidence of malnutrition. So this is chiefly for looking at complications. So depend on your physical examination, you might have to look at specific systemic findings, like if you are suspecting some form of chronic GN like lupus nephritis, then you need to look for organomegaly as well. In setting of nephronopathy, there are many extrarenal manifestations ranging from developmental delay to cerebral atrophy to thoracic dystrophy. So and then retinitis pigmentosa. So depend on your physical examination, you have to look at specific systemic examination. Coming to the investigations, so these are the list of essential investigations which should be done in each and every patient who is coming with the diagnosis of chronic kidney disease. So these investigations are focused based on detecting the underlying etiology as well as the associated complications. So blood creatinine is chiefly to look at the severity or stage of chronic kidney disease. Urea to look at severity of uremic toxin accumulation. Then you need to have there might be the dyselectrolytemia and metabolic acidosis. Then to look for mineral bond disorder, you need to have serum calcium phosphate, ALP, PTH, vitamin D. Complete blood count and peripheral smear to look for CKD associated anemia. Then evidence of the iron profile. You need to look for to determine the further management. Then urine routine microscopy and proteinuria chiefly to look for the underlying etiology as well as prognostication purpose, as we have seen that proteinuria, worsening with proteinuria might have rapid progression to CKD. X-ray, ECG chiefly to look for left ventricular hypertrophy related to chronic hypertension. Do we have like any further answer for that particular question? Hello.
Yeah, it's okay.
So
Yeah, back to test one.
anybody would want to answer? Yeah.
Obstructive uropathy AKI on CKD. And the history of UTI is there or not? Somebody wants to ask. Previous history of UTI is there or not?
No history of previous UTI.
Okay. So the current answer is regarding stream of urine. Another question.
So as mentioned in history, there is history of dribbling of urine.
Yeah,
so
right.
Already there.
So our audience think it is obstructive uropathy. It's an AKI on CKD.
So yeah, it's based on whatever history or examination data is there, is likely to be a case of chronic kidney disease that has acute triggering event leading to maybe like severe hypertension, as well as there is a pedal edema, so there might be evidence of fluid overload as well. So in this patient, as I enumerated, all the essential investigation, you want to do it looking for additional complications. So in this patient, you can already see that there is the hypertension is there, there is anemia already there, and they have stenting as well, wasting. So we'll move forward. So once you have essential investigation, history, and physical examination, you should be like at least 70 to 80% assured that what is the underlying cause we are looking at, and you can further proceed on a special investigation depending on your physical history and examinations. If you are suspecting that this can be a cause of underlying cause can be the abnormality of congenital abnormality of urinary tract, you need to maybe like relook at ultrasound and further clue for underlying etiology. Depending on the history, you might proceed with MCU or maybe MR urography. DMSA scan does have very limited role once patients come with advanced chronic kidney disease. So maybe beyond stage 3 of CKDs hardly provide any clue. But if you are suspecting some PUJ obstruction or something like that, you can look at renal dynamic scan. If there are there is hematuria or microscopic hematuria and there is proteinuria and there is history of edema, then you might be suspecting the chronic glomerulonephritis. So you might to look at serum C3 level, ANA, and ANCA. Kidney biopsy does have some role to play, but one need to understand that there is high risk of bleeding if patient is coming with chronic kidney disease. So if you have relatively shorter history, like maybe 3 to 6 months, and you are suspecting some chronic form of GN, you might go ahead with it. But again, if you are suspecting congenital malformation or some inherited disorder, then I don't think that it would provide you much of extra advantage of doing kidney biopsy. Similarly, if you're suspecting some inherited disorders, so clue which you might get from family history or some other extra renal manifestations are there, then it's likely to be some inherited disorder. Then you can go for next generation sequencing and genetic testing. So at the postgraduate level, at least you people should be aware of that. If you have a patient with chronic kidney disease coming to stage 2, 3, then there are the intervention by which you can prevent the rapid progression to end stage kidney disease where patient has to go undergo dialysis or transplant. So chief risk factor currently reported in literature are one of them is proteinuria, as I have already highlighted in KDIGO heat map. Then uncontrolled severe hypertension would lead to rapid progression to SRD. Then it's also depend on underlying etiology, whether it's glomerular or non-glomerular. Other factors which might contribute are like uncontrolled metabolic acidosis, dyslipidemia, severe anemia, hyperphosphatemia. Then there are certain inherited risk factor like APOL1 gene variant. So in this figure is showing that if you have 2 copies of the mutation or defective APOL1, your progression to ESRD is much faster compared to if you have 0 copy or 1 copy of APOL1. So as I mentioned that patients who have, so this figure is looking at the glomerular underlying etiology and a progression to ESRD. This is non-glomerular etiology. Then these further subdivided based on proteinuria. So if you look at, this red color line is depicting the proteinuria, urine protein creatine ratio of more than 2. So progression to ESRD is much faster in patient with higher proteinuria. But if you look at glomerular versus non-glomerular etiology, at end of 2 years, this almost 80% patients are progressing to ESRD in glomerular etiology compared to non-glomerular etiology, where you have only, roughly maybe 60% patient. So that's kind of, again, one of the important risk factor for progression to ESRD. So this figure is again showing same thing, that if you have underlying etiology as glomerular etiology, then your decline in GFR is much faster. So if you look at this FSGS, so annual decline is almost like 13.3 compared to the non-glomerular etiology. So it's almost like with glomerular etiology, almost 3 times higher for rapid loss of your estimated glomerular filtration rate. Coming to another important risk factor is, the blood pressure uncontrolled hypertension. So this landmark trial clearly showed that if you have intensified blood pressure control, your progression to ESRD is less compared to if you have like unmentioned blood pressure. So currently recommended blood pressure control is somewhere, the 50 to 75th centile to prevent the rapid progression to ESRD. The chief management strategy in CKD hypertension, apart from, the antihypertensive, you need to pretty careful about fluid and salt restriction. So it has to be like very strict, especially in stage 4 and 5 of CKD, but that to depend, the overall urine output and the other things. But you have to be pretty meticulous about these things. So if drug of choice is enalapril, if your GFR is more than 25 to 30, below that there is, associated risk of hyperkalemia and other things with ACE inhibitor. So there you can use amlodipine, prazosin, and labetalol. Coming to the complication of chronic kidney disease, so 4 main complications are anemia, metabolic disorder, hypertension, and growth failure. Apart from that, you can have metabolic acidosis, dyselectrolytemia, cardiovascular morbidity, then symptoms related to, uremic toxins, whether it's pericarditis, poor appetite, and other things. So CKD anemia is probably the most common complication, probably the complication which is observed at earlier stage. So it's defined as, hemoglobin less than 5th centiles for that particular age and gender. So these are the cutoffs, and you have like prevalence as high, as 80 to 90% in stage CKD of 4 and 5. The chief contributing factor for anemia in patients with CKD, one is, obviously the erythropoietin deficiency as it's produced from kidneys. Another chief contributing factor of is iron deficiency, which can be of multifactorial in origin. Then you have simultaneous chronic inflammation going on. There might be bone marrow suppression secondary to hyperparathyroidism and uremic toxins. And people have also seen that there is, decreased RBC lifespan. Then there might be other contributing factor of malnutrition there. So this figure is chiefly looking at, the various factors again contributing to anemia and CKD. So you have decreased EPO production, and this hepcidin does play a key role, which I will be explaining in a subsequent slide. So its excretion is reduced because of chronic kidney disease, then there is inflammation. Then you have the increase, the RBC lysis because of increased inflammation and other factors. And there might be bone marrow suppression secondary to uremic toxins. So chronic inflammation, as we know that the anemia of chronic disease is, secondary to your chronic inflammation. So if you look at this figure, this is explaining from, common progenitor leading to erythropoietic precursor and going through various phases of erythropoiesis and ultimately forming the RBC. So this stage of, conversion of this common progenitor erythroid precursor is chiefly regulated by erythropoietin. So in a patient with chronic kidney disease, this stage is also affected. Then your this stage of, the erythroid precursor leading to final RBC formation, this is chiefly regulated by iron. So both of these stages are affected in patients with chronic kidney disease, which can be mediated by, the various inflammatory markers in patients with chronic kidney disease. So as I mentioned, hepcidin does play a multifactorial role in patients for anemia and chronic kidney disease. So hepcidin is a protein which chiefly produced in liver. So one of the important, in function of hepcidin that is does, block the ferroportin, which is an important transporter for iron, and it does inhibit the release or, the final reabsorption of iron from gut. So that's why there is, the concept that patient, if you are not improving with oral iron, then you have to give intravenous iron, because especially in ESRD patient, hepcidin level are very high. So even if you give a very high dose of oral iron, it won't be, getting absorbed and it won't be contributing to improving your erythropoiesis. Then another crucial component is whenever iron is stored in reticular endothelial system or macrophage, there is release through ferroportin, and this ferroportin is also inhibited by hepcidin. So these are like, the triple way by which hepcidin inhibit your oral, iron availability for erythropoiesis. And this hepcidin level are, one is because there is a decreased excretion. Another that these inflammatory markers like IL-6 and IL-8 does increase your serum hepcidin level. So this step, the like inability, there is, the iron storage are there in macrophage, but inability to use this iron storage is something called functional iron deficiency, and it's chiefly mediated by hepcidin, high level of hepcidin. So coming to the evaluation of anemia in patients with chronic kidney disease, so you need a complete blood count with, peripheral smear looking at the morphology of RBCs. Then you need to have the markers for body iron status. And as I mentioned previously, that other factors might contribute, because there is malnutrition, there is decreased absorption of various factors. So vitamin B12 and folic acid level should be looked at. So in the stage 3 to 4, you can look at 3 monthly. In stage 5, depend on whether patient is on dialysis, you might have to do it at a monthly level. So these are the, various markers which can be done to look for the iron status of the body. So so there is a serum ferritin, then you can have like transferrin saturation, then percentage of hypochromic RBCs, hepcidin, then soluble transferrin. So currently utilized markers are, the chiefly which we focus for clinical practice are the serum ferritin level and transferrin saturation. So coming to the functional iron deficiency, as I explained previously, there might be, the reticular endothelial cell blockage because of high hepcidin level. Then you might have demand supply mismatch. So this is the concept. If you, patient with hemoglobin 6 or 7 is coming first time to you, and you directly start erythropoietin, your iron status of body might be already depleted. So if you start them on erythropoietin, it might stimulate your erythropoiesis, but there is inadequate iron store. Already the iron store of body are depleted. So erythropoiesis is not going to be effective. So this is the case of demand supply mismatch. So how do we define, diagnose iron deficiency? So if you have hemoglobin less than 11, you need to look at the ferritin and transferrin saturation. So if your ferritin is more than 100 nanogram per ml and your transferrin saturation is less than 20, then it's kind of suggestive of absolute iron deficiency. Coming to the algorithm for management of anemia and chronic kidney disease. So any patient who has hemoglobin level of less than 11 gram per deciliter, you need to look for all these markers to look for underlying etiology. If your hemoglobin T set is more than 20% and your T set of less than 20% and ferritin of more than 100 nanogram per ml is kind of suggestive that there is, you have kind of enough storage in the body, and this is suggestive of anemia of chronic kidney disease. So there you can directly start erythropoietin, whether subcutaneous or IVs, depend on whether a patient is on dialysis, you can give intravenous, otherwise subcutaneous route is preferred. If your transferrin saturation is around 20% and your ferritin level of less than 100 nanogram per ml, then you first need to replete the iron store of the body. So if patient is on dialysis, then you need to give intravenous iron. If it's non-dialysis dependent patient, you can start oral iron therapy at 5 to 6 milligram per kg per day. So indication for intravenous iron therapy, if your patient is dialysis dependent, if it's not responding to oral therapy and you have severe anemia and you don't want to transfuse the patient. So ideally in every patient, until unless essentially indicated, you should avoid blood transfusion in CKD patient because it does increase your risk of sensitization of developing the antibodies, which might be another problematic once you plan for kidney transplantation. So essentially the intravenous iron is calculated by this formula, which is body weight into target hemoglobin minus actual hemoglobin into 2.4 plus this depot iron is kind of, you are trying to replenish the body store. So if it's less than 35 kg, then it's 15 milligram per kg. If it's more than 35 kg, then you can give 500 milligram. So whatever the dose is calculated by this formula for intravenous iron therapies has to be infused over 10 sessions of hemodialysis. Coming to the erythropoietin stimulating agent therapy. So chiefly erythropoietin stimulating agent currently we are using in India is recombinant form of erythropoietin. So before starting erythropoietin, you need to be pretty much sure that there is adequate iron storage there in body. You need to be sure that patient is taking enough adequate nutrition, because as I explained previously, even if you stimulate your erythropoiesis through the erythropoietin, but if there is inadequate iron storage or inadequate other micronutrient which require erythropoiesis like folic acid or vitamin B12 is not going to work. So you need to be pretty much sure that there is adequate iron storage there in body and patient is taking adequate nutrition. So our target for the once we start erythropoietin stimulating agent is to increase hemoglobin by almost 0.5 gram per deciliter. So it should not exceed the 1 gram per month. So if there is a rapid rise of more than 1 gram per month, then you might need to decrease your erythropoietin dose. So once you start on erythropoietin, you need to monitor hemoglobin initially, maybe every 2 weekly. Once it's kind of stabilized, then maybe one to twice per month. The there are adverse effects associated with erythropoietin, which include, the risk of increased hypertension as well as stroke and vascular complications. So these are various formulations of erythropoietin stimulating agent, which is currently available in market. So these lower the darbepoetin alpha and this methoxypolyethylene glycol, these are probably longer acting agents which can be used in once in a month or twice per month, where these alpha and beta has to be given for once or twice per week. So coming to the case number 2. So this 5-year-old boy presented with history of bony deformity since 2 years, e.g. fatigability for last 1 year. On examination, he was found to have blood pressure of 128 by 68 millimeter of mercury. There is a pallor, there is a bony deformity and edema with each height and weight. His lab investigation was suggestive of anemia with hemoglobin 10.1, serum creatinine of 3.2 with these parameter of calcium phosphate, ALP and vitamin D. Then sodium potassium of 132 and 4.3 with some bit of metabolic acidosis. So anyone want to take for underlying etiology, or you want to ask further history and examination? Hello? Hello?
Audience are asked to post their answers and doubts in chat box. Any questions regarding the etiology or any other questions do you really ask regarding this case scenarios? You can also unmute yourselves and ask. We might progress with one or two slides and then we can come back again.
Okay. The next complication of chronic kidney disease is mineral bond disorder. So it's defined by any alteration in your serum level of calcium phosphate, ALP, vitamin D, PTH, or there is alteration in bone histology of linear growth, or there is evidence of extraskeletal calcification. So important thing, while considering the mineral bond disorder in pediatric population, that we need to consider, the growing age and requirement of this growth parameters, as well as, physiological alteration or perturbation in the these markers. With obviously with change in the age, you might have different parameters and different requirement, which is contrast different to your adult patients. Manifestation of chronic kidney disease mineral bond disorder can vary from stunting to severe bony deformities. There might be the muscle weakness. You might have extraskeletal calcification, then hyperparathyroidism and other stuff. So these are like varied manifestation of CKD-MVD in pediatric population. Coming to the pathophysiology, which is probably the most complex part of this presentation. So I want to focus on these 3 things. So there are 3 key players in the pathophysiology of CKD-MVD. One of them is the activated form of vitamin D. Another one is FGF23. Then you have PTH, parathyroid hormone. So they kind of interact with each other. So one of the initial crucial probability triggering event is increased FGF23 synthesis. So this is chiefly produced from osteocyte. So FGF23 plays 3 major roles. One is that inhibition of 1-alpha hydroxylase, inhibition of PTH secretion, and inhibition of the sodium phosphate transporter in the kidney, and that's why there is decrease of phosphate excretion. Contrary to this thing, this FGF23 synthesis is increased by vitamin D as well as PTH. Coming to the pathophysiology of CKD-MBD, still, the ongoing research, we don't know what exactly the initial triggering event, but probably increased synthesis of FGF23 from osteocytes is the initial triggering event. So once you have increased serum FGF23 synthesis from osteocytes, it leads to the inhibition of one alpha hydroxylase. So there is decreased synthesis of activated vitamin D, leading to hypocalcemia, and is hypocalcemia is a potent stimulator of PTH secretion. But FGF23 does inhibit the PTH secretion initially. So if you have hypocalcemia mediated PTH secretion, it will lead to demineralization of so this lead to demineralization of bone as well as the probably secondary hyperparathyroidism is if it goes like uncontrolled stimulation of PTH secretion. Sometimes you would have drop in GFR leading to phosphate retention, and as we know that hyperphosphatemia is again a potent stimulator of PTH secretion, which ultimately culminate in hyperparathyroidism and demineralization of bone. So one would wonder if you have the FGF23 increase in serum, it would lead to the phosphaturia, because it does inhibit your sodium phosphate transporter in the tubules. So why doesn't it happen? So probably explanation to this part is that there is clotho deficiency, or there is end organ resistance to both FGF23 as well as PTS. So that's why they are not able to excrete phosphate through the kidney, which is ultimately the resulting hyperphosphatemia. So hyperphosphatemia is probably the chief distractor here, which is contributing to hyperparathyroidism and is ultimately result in various manifestation of CKD-MBD. How do we diagnose CKD-MBD? So as I explained already, you need to look at the various serum biomarker as well as maybe the X-ray to look for any evidence of rickets. So there are various normative range which you need to keep as per stage of CKD as well as your age of the patient. So one of the important things which I would want to you people should pay attention, that normal PTH level. So once you have higher stage of CKD, a normal PTH level does increase. So in stage 4, normal level is 70 to 110 picogram per ml. By then stage 5 is 200 to 300 picogram per ml. So this is chiefly because as you advance to higher stage of CKD, there seems to be end organ resistance to PTH in the body. So that's why you need to keep a higher serum PTH level, because PTH again is the important hormone for your ongoing dynamic changes in bone. So if you target PTH very low level, even in stage 5 CKD, you would have a dynamic bone disease. So coming to the management of CKD-MBD, so there are various aspects. As I mentioned, that hyperphosphatemia is probably the chief distractor in CKD-MBD. So hyperphosphatemia can be first initially one would try to manage with the dietary modification. If it's not happening with that, then you use phosphate binding agents. If it's not happening with that, then you have to go for kidney therapy. So coming to the dietary management of phosphate, so with the if there is hyperphosphatemia, try to restrict the dietary intake to up to like 70 to 80%. But one can restrict it too much, because one of the major problems that whatever food is rich in phosphate also rich in protein. So if you restrict too much of phosphate intake, there would be restriction of protein intake and would ultimately contribute to growth failure. So you don't want to do that. So these are the various phosphate binding agent currently we have for children. So probably lanthanum carbonate is currently not recommended, or there is no evidence to use in pediatric population, but you can use the calcium-based binders like calcium carbonate, calcium acetate, and sevelamer. So if you fail to control hyperphosphatemia with adequate dietary control and the optimal level of this phosphate binder, then your next option is probably dialysis or transplant. So coming to the management of vitamin D deficiency in chronic kidney disease, while there is no standard recommendation, this is the roughly guideline one can follow, that if you have severe deficiency, 60,000 international unit weekly for 4 weeks, then you can taper down slowly. If you have like bit higher level, then you might just give it for like monthly dosage of 60,000 international unit. So as we have seen that one of the chief problem with vitamin D is because there is increased FGF23 leading to inhibition of 1-alpha hydroxylase and not allowing formation of activated vitamin D. So if you are, despite controlling your hyperphosphatemia, if you are not able to decrease the PTH level, you might would think of using the activated vitamin D, which is calcitriol. But before starting the calcitriol, you need to be pretty sure that your 25-hydroxy vitamin D levels are adequate. You have phosphate levels under control, and your calcium level is under less than 10 milligram per deciliter. Because once you give activated vitamin D, it would increase both your absorption of both your calcium as well as phosphorus from gut. So other options are, if you like fail to control PTS level with all these measures, then either you have to use the cinacalcate, which is basically a calcium sensing receptor in parathyroid gland. Then you might consider that the last option is parathyroidectomy. So if you have persistently high parathyroidism or PTH level of more than 1000 nanogram per ml, then you might have to do parathyroidectomy, because this much of high persistent level would have multiple consequences. It will lead to fibrosis in bone marrow. It will lead to destruction of your bones and other consequences as well. Coming to one of the crucial complications of chronic kidney disease, which is more important for pediatric population, if there is malnutrition, and which is again like resulting in further growth failure. So for pediatric population patient with CKD who have malnutrition, there is a specific term used called protein energy wasting, which is to be used in context of CKD only. So there are multiple aspects which lead to protein energy wasting in CKD patients. So it's there is anorexia, which is again contributed by the uremic toxins leading to decreased appetite, and then you have inflammatory stage, which is again suppressing your appetite. Then you have the acidosis and anemia, which is contributing to your decreased appetite. Then ultimately these malnutrition, uremic toxins, and inflammation kind of culminate into final something called protein energy wasting, which has multiple consequences. Apart from growth failure, it will lead to cardiovascular complication. There has been report that it does increase your mortality as well as hospitalization rate. So just for you people, that how does the protein energy wasting is different from malnutrition. while both of these state are, the energy depleted state. In malnutrition, you have good enough appetite, but few is kind of depleted. Metabolic rate are pretty high because there is ongoing inflammation, uremic toxins, and so many things are going on. So there is increased metabolic rate in patients with protein energy wasting. Then another important thing is, that once you increase the energy intake or calorie supplementation, your malnutrition does respond adequately, but that's not the case of protein energy wasting or cachexia. So what do we have recommendation for nutrition in CKD patient? That energy intake should be targeted to almost like 100 to 120% of RDA. Protein intake is probably higher. So, from 1.2 to 1.5 gram per kg per day, more so in patients who are on peritoneal dialysis or hemodialysis, where you would have like loss of proteins. So another crucial important is like, there is significant growth delay, especially in our resource limited setting, where patient does end up, coming in advanced stage of CKD stage 4 and 5. So recommended growth hormone therapies does help in improving their linear growth, but before starting recombinant growth hormone therapy, one need to be pretty sure that you take care of nutrition, so nutrition has to be adequate. You take care of anemia, you take care of metabolic acidosis. So all these things with complications are there. Their treatment has to be optimized before you even can think of using growth hormone therapy. So if you use growth hormone therapy without, taking care of all these factors which are responsible for growth failure, is going to be useless. It's not going to improve any of your linear growth or height. Another complication is, the metabolic acidosis, which is chiefly contributed by either your increased dietary acid load. So animal protein does contribute to, the diet acid load much more compared to vegetable proteins. So one always, recommend taking protein through the, vegetable diets. Then you have decreased excretory capacity of kidneys to excrete the acids, which is chiefly contributed by decreased ammonium synthesis from proximal tubule, as well as bicarb reabsorption. So as we talked about, the progression to ESRD. So if you look at this figure, this is clearly showing if your serum bicarb level is less than 18, then progression to ESRD or CKD and stage of CKD is much faster compared if it's your serum bicarb level is high. So by metabolic acidosis in CKD contribute your kidney damage in multiple ways. The acidemia has been reported to stimulate and contribute to further drop in GFR. Then there is seems to be a complement activation further, increasing their fibrosis. So therapy chiefly is soda bicarb supplementation. So you would start with 1 millicalent per kg per day, and you target more than 22 millicalent per liter of serum bicarbonate concentration. But one should not go overboard also, because if you have give too much inhibiting hypertension, that there is a risk of nephrocalcinosis and hyperkalemia as well. Coming to the kidney replacement therapy, so there is no fixed single cutoff which can be used for deciding that when patient would require long-term kidney replacement therapy. So a gross estimate is 6 to 8 ml per minute of body surface area of GFR. But even if you have higher GFR, if you are not able to control the fluid overload, or there is a refractory hypertension, or there is, the symptoms related to uremic toxins, then you might even have to start kidney replacement therapy even at like GFR of 15. So options we have currently are like whether to go for dialysis or kidney transplantation. In dialysis, you have option of peritoneal dialysis or hemodialysis. So if you go directly, patient go receive directly kidney transplantation, then is known as preemptive transplantation, and is these patients has to be shown have better outcome compared to somebody who goes through the hemodialysis and then receive kidney transplantation. So which modality is better, whether to go for maintenance hemodialysis, peritoneal dialysis, or kidney transplantation? So these figures are clearly showing that if you receive kidney transplantation, then risk of death is pretty lower compared to maintenance hemodialysis. Among these, even best, the survival chances with the kidney transplantation, and probably least is with maintenance hemodialysis. PD is pretty much closer to your dialysis. This figure is again showing, the life expectancy if you start management of ESRD with transplantation compared to dialysis. So give it 10 year or 22 year compared to a transplantation might be 56 years. So why to prefer transplantation over what? Just one or two slides. So kidney transplantation is overall maintenance cost is probably, in a lower with transplant compared to CAPD and maintenance hemodialysis. So I would leave you with this slide. So chiefly, that your staging as per EGFR and proteinuria category does determine the rate of progression and overall further management strategy. You need to frequently look for complications associated with chronic kidney disease and manage them as optimum as possible. Then kidney transplant is probably the ideal and best modality we currently have for long-term kidney replacement. So yeah, I'm done, Georgie.
Very nice overview, Dr. Jitendra, regarding security in such a big period. I understand that it's difficult to do justice within 1 hour on this topic, but we have some of the questions which we can go through quickly. So mostly the regarding CKD with no biochemical evidence of melanoma disease, but having visible rickets, should we will start for phosphate binders and vitamin D? I think more of a theoretical question rather than a practical entity. CKD with
thing is, employees